Good morning, everyone. Can you hear me? Um, this is my first time to have a class with a student from the International Medical University. My name is Wei Qiu. I'm very honored to have a chance to interact with you. And as far as I know, you are all students from uh, the third year or 4 years medical student, and I, as I reflect, I think this is a great period for you, and this is a very, let's say, very precious moment to learn new things. And I do hope that in this class, you can learn about the ocular structure and the common ophthalmic examination. And so let's kick start. And during this lecture, if you have any question, you are welcome to pose your question. Um, and I actually like to have more interaction with the students. So during the middle of the class, I might ask you some question, and if any of you have responded, and I would ask score for you. And no matter what kind of answer you have for me, no matter it's a correct one or it's a incorrect one, that doesn't matter. I just want you to be able to speak out, be not afraid of asking question, or be not afraid to to even challenge your teacher. That would be good things. And so this is a table of content we would like to deliver today. We will start it from the anatomy of the eye to basic ophthalmic examination, and then to the functional test. Then we have some examination for the patient with strabismus. How do we examine this patient to see if the patient have strabismus or not? And then we will cover the visual field and visual pathway. This is important for the patient who have glaucoma, as well as some neuro ophthalmology problem. And then we would introduce common anterior segment examination as well as post-segment examination. And then finally, we will cover the more sophisticated examination, such as electroretinogram, visual evoked potential, CT, and MRI usage in the field of ophthalmology. First of all, let's take a look at the anatomy of the eye. So this is a cross-section of the eye. In the front part, you could see this transparent tissue called cornea. So this is the most anterior section of the eye. Then you have this upper eyelid, lower eyelid, and the actually this tissue over here is covered with conjunctiva, and this tissue, these are sclera. And as we go from the anterior part to the middle and the backward of the eye, you could see that you pass through the anterior chamber. Then you have lens. Then you have vitreous, and on the back of the eye, you have the retina. And finally, you have the optic nerve. So when the light travel from the cornea, they would go into, this is a pupil. They would, some light will be blocked by the iris, the pupil, but some light could pass through the pupil and go into the lens. and because the lens has the ability to adapt, it could reflect the light, so that we could try to focus the light into the retina, so that you could get a better image. But if a patient have myopia or astigmatism or hyperopia, the focus of the light would not be on the retina exactly. So that would cause the uh, decrease in vision. We call that the patient would have spherical error. The spherical errors. So you need glasses to correct those errors. So um, so that the focus will be on the retina again. Okay, then the retina receive the signal from outside, and they pass through the signal to the optic nerve. And optic nerve could pass this information to our visual cortex, to our brain, that is located in the occipital lobe. It's in the back of the head, and then over there you could interpret the image. What did you see? Okay. Then this is um, a greater detail looking at the drainage system of the eyes. So you could see that um, our ocular tissue actually need to nourish the nutrient of aqueous. Aqueous is a fluid that contain a lot of nutrient, especially high in the concentration of vitamin C, which is a very strong uh, uh, antioxidant, and that would help protect uh, the free radical uh, from damaging the ocular tissue, so that the eye, the cell body, constantly would produce these aqueous, and the aqueous would leave from the cell body, from the posterior chamber, and move through here to the anterior chamber. And then where does it go out of the eye? It was drained from the trabecular meshwork. There's a snake canal over here. So the aqueous was produced by the cell body. Then it was drained out by the snake canal, trabecular meshwork, so that and it would go back to venous system of the eye. And so in a healthy eye, you need to maintain a good, adequate intraocular pressure. So if you have compromised cell body production of the aqueous, then um, if you don't have if you don't have sufficient production of aqueous, the if you imagine eyeball as like a basketball, if there is an inadequate production of the aqueous, do you feel the eyeball, the basketball would be too soft or too hard? So I think you become too soft. Okay, we don't like our eyeball to become too soft because that will compromise patient's visual function as well. But on the other hand, we don't want our eyeball to be too hard. That would cause problem too. That could cause the damage to the optic nerve. So when would you see a rise in the intraocular pressure? So this is a drainage system, so in the eye. So if you see that there is a blockage of the drainage system in the eye, then uh, the aqueous could not move out of the eye. Then the pressure will build up in the eye. Then if it exceed the normal range of the intraocular pressure, which is defined as 21 millimercury. Let's say if you have a intraocular pressure of 30 millimercury or 35 millimercury, in the long run, it could damage the intraocular structure, especially the optic nerve, and compromise the patient's vision. So to maintain a good intraocular pressure of the in the eye, you have to have a healthy drainage system. You need to have a healthy ciliary body and you have to have the healthy route without blocking this transport of the aqueous, so that it could maintain a good health. So you could see that these through the mesh trabecular meshwork, that would be drained out from the venous system, so that our eyeball could maintain a good intraocular pressure. So this is a very intricate process. So for example, there is a disease called glaucoma. Uh, do you know what causes glaucoma? And I ask a couple questions from the students. Um, the the student named Lim Su Yun, number 1. Can you hear me?
Yes.
Yeah. So, Dr. Lin,
Yes.
so have you heard of glaucoma?
Yeah, it's a condition where there's an increase in intraocular pressure in the eyes.
Yeah, very good, very good. So, if there is an increased intraocular pressure in the eye for too long period of time, that could compromise the patient's visual function. And so as I mentioned, that the usually the problem is in the drainage system. Rarely would we encounter the problem that's in the overproduction of the aqueous. So we have medication or surgery that would uh, uh, be invented trying to improve the drainage or block the production of the aqueous. So you can see that under glaucoma condition, you have either topical eye drop to block the ciliary body production or help the drainage of the aqueous, or you have surgery. If that doesn't work, the medication doesn't work, you have surgery. You could make a channel here trying to uh, reduce the pressure in the eye, so that the pressure could be maintained adequately within the eye. So you understand uh, the importance of intraocular pressure uh, in the eye. So as I told you, I mentioned to you that the normal range of the intraocular pressure. Do you know what is the normal range? Do you know the normal range of the intraocular pressure? Uh, Usually, it's we define the normal range of intraocular pressure was less than 21 millimercury. But we don't want the pressure. So if you have pressure of 10, 15, 18, even 18, that was considered to be normal. But if you have a very low pressure, that could cause problem too. If you have a pressure of 5 or less, that was considered a condition of hypotony. Hypotony would cause compromised vision as well. So not always, we don't want to have a pressure too high, but we don't want to have a pressure too low either. Okay, so thank you for responding to my question. So let's move on. Then we would move to the basic ophthalmic examination. So this is a SLAM biomicroscope. This is the most essential instrument in ophthalmology clinic. And basically, we just use the light to become a slit, a very thin light. It would become like a optical knife that could cut through the ocular tissue. So do you know what this refraction, what is the what did this image stand for, and what is the refraction noted on the corneal surface? Let me ask our, okay, number 7, Benjin Chin. Can you hear me? Benjin Chin, number 7. How about number 8, Ho Ek Ten? Do you know? So Jing Yin Dulei, this is their number. Number 11, Te Yi Ling. Can you hear me? Jing Yin， 他们我不知道他们有没有上线。
就我们现在名单的部分，还是部长我帮您。
没关系，没关系。Okay, that's okay. So I hope that we could have some. So so you can see that this is an instrument that could help you evaluate the condition of the external eye, including the eyelid, eyelash, and the cornea here, conjunctiva, and the lens, even the anterior vitreous over here. And so why this is essential? Because with this instrument, you could evaluate a significant proportion of the eyeball condition. For example, like this case, we use a fluorescent eye strip, then we could scan the cornea surface to see if there is any cornea defect here. Okay. Then like for example, this case, you see a cornea defect, then we know something wrong is here. Okay. Then we have the direct ophthalmoscope examination. This is also more specific instrument for ophthalmologist. Probably you need to master this with a couple of practice. So the doctor's right eye will check into the patient's right eye, and in the field you could see the mainly the posterior pole structure. You could see that this is optic disc. This is retina vessel. Macula is here. The center of the macula is called fovea. This is the most important part of the of the of the of the of the of the eye because it's responsible for the central vision. Okay, then you could actually see that these vessels usually there's a artery come with a vein, so you could see that the bigger vessels are artery. No, that's wrong. Bigger vessel are vein, and the smaller vessel are artery. Okay.经营，it's 经营有可能让他们都打开那个视讯吗？
可以。
So, yeah, I'm thinking if possible, could our student turn on your video, your camera, so that I could interact with you directly. Um, I think that would facilitate the efficiency of learning. Then in the clinic, you must have seen this chart, visual acuity chart, to document the patient's vision. So you could see you have uh, a bigger letter, then gradually to a smaller one. So if you could tell these where these deficit of the circle is, that means you have the resolution to identify these characters. So if you could identify the smaller defect on the later chart, that means you have better vision, and you have different kinds of character. You have C chart, you have E chart, and this is a ETDRS chart. This is a standard chart for use in a lot of clinical trial, clinical study. It takes longer to perform this chart, but it's more accurate. You can see that each line, they have same number of character, and uh, also the proportion of the difficulty of the letter are different from the traditional chart used in the clinics, because it was specially designed to reflect the gradual changes of vision from the patients. So this is a basic uh, 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 denotation of the chart you get. So for example, you would hear a lot of people saying that I have got the vision of 2020, and I have a vision of 2040. So do you know what does this means? So let me ask, so Dr. Lim, are you still there? Lin Su Yun,
Oh,
number one. So do you know what
yes.
does Vision 2020 means? If
20.
let's say,
Okay. Let's say what?
yeah, you say, let's say if a patient have a vision of 2020 or 6/6, so see, depending on which system you use, they basically are the same, identical. Uh, if you use a meter, this is 6/6. If you use feet, that's 20/20. So do you know what does this means?
Let's say 6 to 6 means that patient can see up to at the at the distance of 6 meter, patient can see up to the level 6, is it? Full means that the visual acuity is full.
Good, Very good. I think and then how about let's say 6/12, 20/40? What does this mean? Does 20/40 have a better vision or worse vision than 20/20? Which one has better vision?
6/6 is the full vision. So going down, the visual acuity is much poorer.
Very good, very good. So uh, 6/6 actually means that for normal people, they could see the object at a distance of 6 meters. You could also see that object at a distance of 6 meters. And in the 6/12, that means for a normal individual, they could see the object at a distance of 12 meters, but you need to see the object at the distance of 6 meters. So that means your vision was only 6/12. That's equivalent of 0.5 in decimal notation. Okay, so 0.5 vision was worse than 1.0 vision, but this is not like you could say that the vision of 20/20 is twice that of 20/40. They are not their relationship are not linear, so you have to transform to Glaucoma vision over here. This is a minimum angle of resolution. After you transform to a log, that is a little bit complicated, but after you transform it, then you would get a linear relationship. So if you transform to Glaucoma vision, then you could start to do the average subtraction and calculation. Then you have to convert it back to the decimal notation or the Snellen fraction, so that you understand what are their average visual acuity. Okay, so this is the vision test we have in the classroom, in the ophthalmic clinics, and usually we don't show them all these characters. Do you know why? So we use a light box to check the patient's visual acuity. So why don't we use why don't we show them all these characters at the same time? Why do we use a light box? Is our patient student number 2, Lin Yi Chun? Are you there? I can only see one student here. 经理，您可以请他们都秀那个 video 吗？ So
有，
对对对，
对，我们有请他们打开。
可是我只有看到一个学生，哦，有很多哈。OK
他们陆陆续续
OK，
打开。
Chen Ai Shun，
Yes, please switch on your camera so that we can see you and have more communication.
Okay, good. I can see you right now. So Chen Ai Shun, do you know why in the clinic examination we don't want to show them all the character?
Doctor, I'm not so sure.
You're not so sure. Okay.
Yeah.
Yeah. That's because some patients are very good at memorizing all of these characters. So if you show them all the character, they probably they don't they could memorize it, and so actually they do not see these chart by their eye. They just memorize it. So you could get incorrect measurement of the patient's vision. But if we just show the character randomly, we just show them once per one character per examination, then there's no way they could memorize those characters. So we could get a better assessment of the patient's vision. Okay. Then we
Okay, doctor.
yes. Do you have question?
No, understand. Thank you.
Okay. Then how about kids? For kids who are really tiny, who couldn't express where is the defect of a circle, and then we could show them this card. We have various cards that's been validated before. That's equivalent to certain vision. So we could, for example, we show this card to a young children. We could ask them, do you know where is the fish? Where is the apple? So that we could have assessment of these these patients' vision as well. Okay, and not only could we measure the patient's visual acuity. Visual acuity is essential. We could also measure even higher function vision performance of the patient. For example, like contrast sensitivity. You could have a patient who have very good visual acuity, but poor contrast sensitivity. Okay, then the patient could have good resolution of the defect on a visual acuity chart, but if contrast sensitivity, the contrast between uh, between its surrounding, if the distinction are not so obvious, they have difficulty of recognizing these contrast sensitivity, then he could have compromised vision as well. So we have way, if let's say the patient have good vision, but still there's a complaint that he could not see the object well, then you could perform other tests, for example, contrast sensitivity test, to see if the patient have a problem of contrast sensitivity or not. Then, as I told you that intraocular pressure is very important. So we have various instruments to measure the patient's intraocular pressure. So this is called the tonal pen. This is eye care. This is a pneumatic measurement. So it emits a stream of gas, and it measure the gas coming back from the patient's eyeball. Then you could have the measurement of the patient's intraocular pressure. These tools are all very important. If you become a ophthalmology resident in the future, you need to master this technique. Maybe in the future, when you rotate to ophthalmic clinics, when you are internal clerk or PGY student, you will have the chance to perform this test for the patient. I would definitely encourage you to do it by yourself, so you have better feeling about the patient, how you could try to improve the patient's level of comfort when you do the examination for them. Okay, So why do we need to have these tests all together? Why can we just use a pneumatic measure to measure the patient's vision? Coating Zhang? Coating Zhang?
Oh, yes, doctor, I'm here.
Yeah. Could you tell me why do we need to have these various kinds of instruments?
I guess one of the factors is can be cost, like maybe some devices are expensive for people, so they have, and then also if just one kind of the device, then it may not be reliable to for all people.
Oh, very good, very good. I think
Yeah.
you have covered majority of the reason, but one thing is that you could see that if you have a bedridden patient, can you use a pneumatic method to measure his visual acuity? Probably you
Uh,
cannot, right?
Sorry,
Right.
could you repeat that again? Yeah.
If you have a bedridden patient, the patient is lying on the bed, okay?
Okay, I see.
You cannot
Yes.
use a pneumatic. He has difficulty of sitting on a chair, putting his chin on the chin rest.
Oh,
Right.
yeah, I get it.
So you need to
Yeah.
have handheld devices to measure patients' visual acuity. Uh, so you need to have different devices for different patients. Okay. Then we have
Okay.
other vision function test. So one of the important examination is the examination for the pupil. So you know the pupil responded to light, right? So if you have a light, the pupil would dilate or constrict, Wallen take home. Would when you have a light pointed at the patient's pupil, would the patient pupil constrict or dilate?
It will constrict.
Constrict like here.
Yeah.
Very good. And so when you move your light pen to the other eye, so by the time your light pen move away from it, you see the pupil dilated again, right? Because
Yeah.
the stimulus was removed. But when you redirect your light pen over here, would you see the constriction of the pupil again?
Of the same eye, is it, doctor?
Yeah, when you move your light pen from here to here, initially the pupil, you see it was dilated again. Then when the light aim at the pupil again, would you see the pupil constricted or
Yeah.
dilated again?
Constricted.
Yeah, it would constrict it. And if you see the contralateral eye at this time, you will see that the pupil actually was constricted as well. So it would be a constriction of bilateral eye, not only one eye. But let's say there's a scenario of if you have a light pen here, I mean at the patient's right eye, pupil constrict, and you move to the left eye, the left eye was dilated, the right eye was constricted, then you know something is wrong. Okay, so this is the visual pathway for the controlling of the pupil. So this is a cranial nerve, second cranial nerve, optic nerve, and this is oculomotor nerve. Okay, so you could see that there is a optic chiasm here. So our optic nerve send fiber, send this signal not only to the ipsilateral eye, but also send a signal to the contralateral part of the brain. Okay, then the visual cortex, I told you that we process the signal at our visual cortex, which is at the occipital lobe. It would send the signal to our third cranial nerve. Okay, it's bilateral. Okay, so for example, if the patient, let's say this is the patient's right eye, this is patient's left eye. If a patient have the let's say this optic nerve damage here, okay, so when you shine your light source here in front of the patient's right eye, what would you see? Would you see what would you see in this eye and this eye? Would the patient's pupil constricted if the lesion was here? Let me ask another student. Ida.
Yes.
Yeah. Do you understand my question? So if the patient have optic nerve lesion here, over here, of the left eye, in the left eye, and I shine my light source on the patient's right eye, what would you expect to see at the of the patient's pupil in the right eye and the left eye? Would you see the pupil constricted in the right eye?
Yes.
Yes. And would you see the pupil constriction as well in the left eye?
Yeah.
If you will see it constricted as well, right?
Yeah.
Because the visual, you have signal here, you send a signal here to both eyes, right? Then
Yeah.
you would come back from here, So it would not affect the signal pathway because the lesion was here, right? So
Mm-hmm.
you see the constriction of both the right eye and the left eye. So how about when you switch light source to the left eye and you have optic nerve damage here, then would you be able to see, what would you see of the pupil in the right eye and the left eye? What would you see?
If the light source is changed to the right eye, then the right eye will still be constricted, but I think the left eye wouldn't be constricted since
Yeah,
there's damage.
yes. So how about right eye? When you switch the light source to the left eye, and would you see the pupil constricted in the right eye as well?
Yes.
Because it's broke here. Okay. If the patient have, for example, trauma or damage of the optic nerve here, so you would see that when you switch light source to here, the pupil would not be able to constrict because this pathway was broke, and also the signal. Okay, for example, for the right eye pupil to be able to constrict, you would need to receive the signal from here, right? But this pathway was also blocked because the light could not be transmitted to here, right? Okay, so you would not be able to see pupil constricted both in the right and left eye. You see pupil dilated in both right eye and left eye. Okay,
Okay.
understand?
Yeah.
Okay, good. So you could use a very simple tool, just your light pen. You could check the patient's integrity of the second cranial nerve, the optic nerve, and the third cranial nerve, the oculomotor nerve. And also, I think all of you might be familiar with this test, the color blindness test. Have you all have this color blindness test before? Ama Moon, Ahmed Muan. Sorry, if I mispronounce your name, but I like to be interactive. Ahmed Moon, can you hear me? Okay. Adriana Moki.
Yeah.
So, have you received the test of color blindness before?
Yes.
And so, do you know what it is used for?
To check.
What?
To check like
To
if you
check.
see the right color.
Yes. So, we have cone cells, three kinds of cone cell that could differentiate red, yellow, and green. So if you confuse one of the color with another, you would not be able to identify these numbers on the chart. So these Ishihara chart actually are very primitive. Also, it's not so well standardized. So this is suitable for only screening, massive screening only because it's easy to use. Clinically, if you want to have a more detailed test for the patient, you could use, we call that 40 hue or 100 hue test. These tests, you could ask the patient to align these color from the most saturated color to the lightest color. Then you could see if the arrangement are correct or not. Then you could give a score for the patients. Okay. Then we also be able to test the patient's sterosis. Do you know what is sterosis? Sterosis, when you all of you go to a 3D movie, if you don't have good sterosis, you might not appreciate a 3D movie that well, because you need to have good sterosis to proceed to understand that there's an object coming up. It's not on the screen only. The traditional movie theater, they only project a 2D image on the screen. But for a 3D movie, the object will come out of the screen. You could proceed because you have good sterosis. So we have a couple ways to measure a patient's sterosis. We use a second of art to measure it. If a patient have a lower seconds of art, that means the patient have good sterosis. Okay. So this is a typical test we have for our patient. It's called Titmus Test. For older kids, we would ask the patient to grasp. We would ask the patient to put on a glasses, like a 3D glasses. Then we will ask the patient to grasp the wing of a fly, and if they could grasp the wing of the fly without touching this plastic panel, then we think the patient has a good or adequate sterosis. But if you want to quantify them, you would have them to test these circles. With this, the glasses on, they could find out one of the circle actually distinctive itself from the rest of them. Then you could see the as you have nine set of circle here. As you advance from the set number 1 to set number 9, the more difficult to appreciate that a particular circle that stand out from the rest of the three. So because it's sterosis become not so obvious. This is the most obvious. Even without putting on the glasses, you probably could see that this circle is a little bit different from the rest of it. But starting the test number 2 is not so obvious. But for the younger kids, they could not understand these so well. You could use the animal down below here. One of the animal, for example, in the panel A, stand out from the rest of it. So you could ask the children to pick it up, ask this child to pick it up, which animal stand out. Then you could document it and get recall of the sterosis of the patients. Okay. And we have also other tests. For example, this Frisbee test and TNO test. Although the patient wear glasses, put a glasses, special glasses on. In the there's a green color and the red color on it. Then we would show them this photo and see how they responded to this test. Okay, then we could estimate their level of the sterosis. So right now it's almost 9 o'clock. I think we could have a break of 10 minutes, and could you come back at 9:08? Okay. We could have a recess of 10 minutes, and please come back at 9:08. Okay.
Okay, thank you.
Thank you. I think we can resume our class. Right now we are going to cover the strabismus examinations. So strabismus was defined as when two eyes cannot fixate on a single object. Okay, it happened in approximately 2% of children. It could be esotropia, exotropia, hypotropia, and hypertropia. So esotropia means the one of the eye has internal rotation, and exotropia means one of the eye has external rotation. Hypertropia means one of the eye was lower than the fellow eye. Hypertropia means the eye has a higher position than the normal positions. Okay, and usually the kids uh, the kids would have more stable eye position after 3 months old. And if you find that the patient, that your kids have persistent deviation beyond 4 to 6 months, you would need to seek medical profession for a detailed checkup. So this is a photo of two patients. So there's one that's really having the esotropia. I mean, the eye, one of the eye have internal deviation, and the other has so-called pseudo esotropia. That means it looks like the patient have internal deviation, but actually it's not. It's still in the normal eye position. Let me see. Uh, Hortin Fan, Dr. Hortin Fan.
Yes.
Hortin Fan, can you hear me? Yes.
Yeah.
So which photo is photo with esotropia, and which one has pseudo esotropia? What's your judgment? Yes.
The bottom one seems to be the pseudo esotropia, I think.
Uh-huh.
And the top one seems to be the esotropia for me.
Okay. Yeah, correct. Why? How did you judge? Which one is? Yes.
Seems like it just seems like the deviation of the right eye of the top picture is, how to say, small, that is more deviated compared to the left eye on the top picture. Whereas on the bottom picture, the deviation like when you compare two eyes, it doesn't seem like there's much difference.
Okay. Okay. So
uh,
the upper photo has more obvious deviation than the bottom one, right?
yeah.
I think there's another tip you could use. That is the light reflex. Okay. So you could see that in this photo, the light reflex of the patient's left eye was in the center, but in the patient's right eye, the reflex was actually at the temporal side. That means this eye has internal rotation. Okay, so this eye is having esotropia, a real esotropia. How about this eye? You see the reflex here. The light reflex was actually in the center of both eyes. Okay, this eye seems to have esotropia. That's because there's a very widened nasal canthus. Okay, these nasal bridges are very wide, so it looks it make you feel that it seems to have internal rotation of the left eye here. Okay, but actually the patient have uh, uh, also esotropia. It's there's no strabismus in this patient. Okay, so with this simple technique, you could have a very close assessment of patient's eye position. Okay, very good. So for any of your all of the students who have help responded in the question, I would ask go for you, no problem. No matter whether you have a correct answer or not. So this is because of these large, could be due to large epicanthal's fold or white nasal bridge. Usually these pseudo esotropia, it would get better because as the facial bone develop, you have less such condition as you get older. And also you could use a machine to check the angle of deviation. Synoptophore, this is a strabismus test, but it's not very commonly used in the clinics. In the clinic, usually doctor use this prism to check the level of deviation. So you have different prism with different power. So when you have placed this prism over the deviated eye, it becomes neutral, then you know the angle of deviation. So you could document how much deviation this eye have with this prism. Okay, so you could see that initially the patient have deviation, but once you place a correction prism here, it become neutral. The light reflex was in the pupil center. Okay, then you know how much angle of deviation this eye have, and the doctor could use this information to help him decide how much surgery, how much amount of muscle shortening would be needed for the patients. Okay. And also you have a case chart, so you could ask the patient to draw these lines. Then you could compare the outcome from the right eye and from the left eye. So usually in the eye examination, patients the data from the right eye usually is placed over here, and the left will be placed over here. It's from the patient's perspective, but the exception. There are two exceptions. One exception is the haste.
I can still take.
The other exception is the visual field test. So the data of the right eye will be field of the right eye will be placed here. Field of the left eye will be placed here. So you could see whether there's a difference between the two eyes. And also there's another test you could use that's called Wolf's 4 dots. And you could see that the patient put on a special glasses. One is red, one is green.
The lives of the entire world. Not one or two.
So you could see that when they were asked to see these light, if let's say if this eye the patient cannot see the cannot see in the right eye, he could only view from the left eye, then you could see that he would see a photo of D, because he could not see the right eye with the red color, you cannot get all the images. So he would see that if he report to you, he could only see 3 green light. You would know that his right eye has a problem. Okay, and if a patient has strabismus, for his right eye, he would see 2 red dot here. For the left eye, he would see 3 green light here. So if a patient report to you, he see five lights, 2 red dot, 3 green dots, then you know the patient have the problem of strabismus because he could not fuse them together. For a normal patient, if because a patient would if there is no strabismus, with his right eye, he would be able to see the 2 red dots here. For the left eye, he should be able to see 3 green dots here, right? But because the green and red cancel to each other, so he would report to you he see four dots and 2 green dot, one red dot, and this was blank. Okay, this was like a white. Okay, so with this test, you could have a very gross assessment of a patient's eye condition as well. Okay, any question? Okay, and also with worse 4 dot, you could also check if a patient have a fusion. Like normally, I say that you should be able to see 4 dots, but if a patient have strabismus cause a diplopia, you will see 5 dots because with your right eye you see the 2 red dots, and the left eye you see 3 green dots without fusion together. So this is abnormal. So if the patient only reported to you that I only see 2 red dots, that means the image from the left eye was suppressed. So you have a suppression, left eye suppression here. So it's not normal. Okay. So this is a process called fusion, sensory fusion. So it's the ability of the 2 eye to integrate visual information over a range of obstacles. So this is a very useful test, especially for kids to see if they have sensory suppression. Then let's move on to the visual field and visual pathway test. So there's a simple visual field test. It's called confrontation test. You could perform for the patient. You ask the patient to cover one eye, then you presented your finger at different quadrant from the superior temporal, inferior temporal, superior nasal, inferior nasal. Then you could see if a patient responded with the correct answer. So you could document whether the patient could have a normal visual field or not. For example, in the figure A, you could see that for the patient's right eye, as I told you, all the orientation of the ocular examination, we place the result of the right eye here, left eye here. The only exception was visual field and the haze chart. We place the data of the right eye. So this is the patient's right eye. he could not see the object in the superior temporal and inferior temporal. So you could see there's a defect in the temporal image. Also in the left eye, we see that the nasal side image was okay, but you could have a counting finger correctly. But in the temporal side, you could not see these image on the temporal side either. So you could see that you have bilateral temporal anopia. So that means the temporal visual field have defect in both eye. Okay, that's an indication of a lesion at the optic chiasm. Okay, so this is a visual defect both from the temporal side. And how about here? This is different for the right field, right eye. You can see there's a defect in the nasal side, and also for the left eye, you also have a defect at the nasal, at the temporal. You have a defect at the temporal side. So in the right eye, is nasal. In the left eye is temporal. So we call this homonymous hemitemporal anopia. So this is an indication of a lesion in the visual cortex. So we could see that this is a more sophisticated machine we use for the visual field test. We call this automatic perimetry. It will show light. Then the patient will need to respond it to the light. Then this is the diagram showing the result of visual field defect and its relationship to the visual cortex, the visual pathway. So this is as I told you, this is a patient's right eye, right visual field. This is patient's left visual field. So in the previous example, like here, you have bitemporal hemianopia. So you have number 3 here, bitemporal hemianopia. The patient could see the object in the nasal field, but not the object in the temporal field bilaterally. So it's called bitemporal hemianopia. It's an indication of chiasm lesion here, optic chiasm here. Why? Because you could see that this is a retina, okay? The retina, the temporal retina actually could sense the visual field in the nasal hemisphere. So if there's a lesion here, you can see that the fiber in the temporal side could still sense the nasal visual field. Okay, so because it's not, you have fiber that's not close here, that's still intact. Okay, but the fiber that would close to the contralateral side was blocked because of this lesion at the chiasm. So this part of the retina could not sense the visual field in the temporal side. Okay, so you could see that the signal could not be sent to the visual cortex for further process. So you will see the patient's right eye would have a temporal defect because the nasal fiber could not send the signal to the contralateral side for a visual cortex to process. Got it? Okay, so for the left eye, you could see that the the fiber in the temporal area could still sense the visual field in the nasal part. So the temporal retina could see the nasal visual field. The nasal retina could sense the temporal visual field. So it's opposite, and so you could see that in the left eye, the temporal retina are still intact. They could still see the nasal visual field, but the nasal retina that's able to sense the temporal visual field has the problem of sending the signal to the contralateral eye because there's a lesion here. Okay, so you will see that this visual field was there's a defect in this field because they could not send the fiber cross the optic chiasm to the contralateral visual cortex for further process. So you will see bilateral temporal anopia. So that's an indication of lesion here. Okay. Okay. So for example, let's say if you have patient have a visual field defect in the right eye, and the left eye was completely normal, likelihood of location of the lesion was at the optic nerve defect in the right eye here, because all the signal from the nasal field as well as the temporal field could not be sent to the visual cortex for process. But the signal from the left eye could be sent to the visual cortex for further process. So you could see that patient presented with a visual field defect like this. So for the, let's take the number, let me see. So I would like to ask some of the question here. Coating Sun, coating Sun.
Yes, yes, doctor.
Yeah. So could you understand what I'm talking about? So this is the optic nerve. This is optic chiasm, optic tract. This is the visual cortex, and actually our optic nerve send fiber to not only to the ipsilateral visual cortex, we also send cross fiber to the contralateral visual cortex. So that's the reason why you see when there's a lesion here, you see a visual field defect like this. When you have a defect here, you see a visual field defect like this. So do you understand what I am talking about here?
Yeah, understand, doctor.
Okay, so this is a little bit complicated, but if you try to interpret it carefully and think it thoroughly, you understand what I'm talking about. So you could see that after the chiasm, if a lesion is after the chiasm, you see that it would have a lesion on the same side here. So in the lesion in the number 4, 5, 6, 7, you see that their lesions are from the same side. Okay, why? Because if you, for example, if you have a lesion at the number 5, because 5 receive the fiber from the right eye, the signal of the, let's say, of the visual field in the the nasal visual field. That's the temporal retina in the right eye was responsible for the nasal right visual field. So this part of the lesion was blocked, okay, as well as this part of the field was blocked because the cross fiber was blocked as well. So you see that from the same side of the visual field would have defect. We call this homonymous. If there's only half visual field defect, we call it hemianopia. Okay, homonymous means they correspond to the similar side of the visual field. Okay, this may take some time to digest the content because the visual pathway was very intricately designed by God, and but it's not difficult to understand it, but you just need some time to figure out the relationship of this defect and the visual pathway. Okay. So then let's move on to the anterior segment examinations. So a lot of time we see the complaint from the patient. They have dry sensation. They use their computer a lot, and they use a lot of. They spend hours on the laptop. They might have a problem of dry eye, or sometimes if they have autoimmune disease like a CCAR syndrome, they might have a decreased secretion of the tear film. And then we clinically we have the test to see if the patient's tear film production was decreased. So this is called Schirmer test. You could use a paper strip to measure the how much tear production the patient have. There are a couple way of performing Schirmer test. You could either with the anesthetics applied to the patient's eye or without anesthetics. If you use anesthetics, that would block the reflex tearing. It would only measure the basic secretion of the tear. And if you do not use anesthetics, then this test would measure both the basic secretion as well as the reflex secretions. And also right now we have a machine that would help us to view the these mammary gland, see if there's any mammary gland inflammation, obstruction that would cause or accompany with a dry eye scenario frequently. So you could see that these mammary gland are the secretion of the oil component of the tear. So there are three components of the patient's tear. It would have the innermost is the mucin layer. central you have aqueous, and the outermost layer are lipid layer. So the lipid layer help the tear from evaporating. So this is important. So the lipid component actually come from the mammary gland. So we also have a machine right now to evaluate a patient's mammary gland status. And also we have a machine called corneal topography. We could be used to measure the cornea curvature and see if there's any abnormality of the patient's cornea curvature. You could not only measure the anterior surface, but you could also measure the posterior surface. And so normally we would use a different color to represent the corneal curvature. So if use the patient outside the normal range of the curvature, they would be presented with either hot color like this red, or they will be presented with very cold colors. Okay, so for example, you could see that there's a hot color, it's red here. So that means the curvature here is abnormal, it's too steep. This is clinically, this is a disease called keratoconus. There's a abnormal curvature here. That's because the cornea structure at this region was particularly weakened. So you have protrusion of the ocular tissue over here. So that causes a abnormal curvature. Okay. And we also right now we also have a machine that could measure the higher abnormality, higher vision abnormality. For example, this is a barometer test that could be used to test the aberration of the eyes. So the wavefront aberrometry is an objective measure of measuring refractive power. We use a tool to measure the manner in which the light beam move through the tested eye. So theoretically, if we send the light into a patient's eye, then the refracted signal should be like a plane. It should be a flatted plane. But if you have condition like defocus, or a patient have astigmatism or coma, the plane become distorted. Then if you have multiple conditions, and it could sum up with a wavefront like this. So it's no longer a flat plane. So right now, in the modern refractive surgery to correct, for example, the patient's myopia or hyperopia, we will not only correct the patient's refractive error, the myopia or hyperopia, we'll also try to correct these high order aberrations. Hopefully, the patient could achieve a better visual outcome. Okay. And this is a machine called specular microscopy. This is used mainly to access the innermost layer of a cornea. It's called endothelial cells. So you could see that endothelial cell should line up each other like the honeycomb. Okay, and you could see the number here, their density. For example, in this eye, the patient's right eye have a density of 3,883, and the left eye have a 2,789. So the left eye has lower density compared to right eye. If the number fell below a certain age, a certain range, then it might pose a risk of when you perform cataract or intraocular surgery for the patient, because after the surgery, the density could further decrease. So you have to be careful before conducting the surgery for your patient, especially the surgery involving anterior chamber, because this is the innermost layer of the cornea that is responsible. The endothelium is responsible for the pumping of the fluid out of the cornea, so that the cornea will become transparent, will become dry. It will not be edematous if you have a healthy cornea endothelium function. So this is we could measure its morphology and the number and the density and its arrangement, so that we could make sure they are healthy. Okay, so usually the cornea endothelium cells are arranged in a hexagonal pattern. Okay, if the patient's number are correct, but the morphology are abnormal, we still consider it's abnormal. So you have to be careful in this patient when you conducted a surgery for this patient. Then let's move on to the prosthetic examination. This is optometry machine. With this machine, you could get the information of, let's say, for example, in here, you could see that patient's actual length. The K1, K2 is a corneal curvature. This is a corneal curvature at a 92 degree and a corneal curvature at 2 degree. Then with this information, this is also anterior chamber depth. You could get these biometric data. This is showing the intraocular lens. This is a residual refraction. So what does this mean? We would use this information before we conducted a cataract surgery for a patient. Then when we remove the patient's cataract, we need to implant artificial intraocular lens to the patient's eye. Then we need to select a correct power of the intraocular lens for the patient. For example, if I choose an intraocular lens with 23 diopter power, I expect that after the surgery, the patient would get a refraction of minus 0.47 diopter. If I want the patient to be at a more hyperopic side, then I could choose a intraocular lens with a power of 22 diopter. Then I expect to get 0.22 diopter power after the surgery. So with this information, I could decide what kind of intraocular lenses I need to implant to the patient's eye, because patient might have different need. For example, if this is a very old patient, he's 85 years old, he doesn't need to read newspaper nor magazine. he just need to have a good eyesight for watching television or take a walk outside. Then you might need to consider using a pulse of refracted error close to 0 diopter, okay? Because he doesn't need to retain any refraction for the reading. So this is a very useful test before we conducted cataract surgery for the patient. And we could also have ultrasound biometry. We could, with this information, we could measure the patient's actual lens. Okay? So this is how we use ultrasound scan to measure the patient's whole scanning area of the eyeball. So you can see that with the B-scan, we could see the information on the lens, on the vitreous, on the retina, and the optic nerve. And right now we have a newer development of instrument called optical coherence tomography, OCT. You could, with this machine, we could get the information from the retina. So you could see that this is a patient of with macula hole. You could see this is a vitreous. Okay, because of the vitreous traction, there's a macula hole and localized retinal detachment. And after successful surgery, the hole was closed again. And we have disc OCT as well. This is for the analysis of retinal nerve fiber layer. So you could have a database to compare if the retinal nerve fiber layer fell below the normal range, it could be shown in red color. If the patient have a healthy retinal nerve fiber layer, it could be shown in green color. And with a further advancement of the OCT technology, right now we have the OCT angiography machine. It could give you information, not only the retina anatomy, but it would also give you the information on the retina vasculature. So you could see the vessel here, and you could see that in the center of the fovea, there is no vessel. So this is a vascular fovea center. So for example, if the patient have diabetes and that cause diabetes retinopathy, there are loss of this retinal vasculature, and the fovea vascular zone was abnormal as well. On the structural OCT, you will see the macular edema here. And we have a fluorescent angiography to help see if there's any abnormal structure in the fundus in the retina. We will inject dye, fluorescent dye, into the patient's vein, and then we could get the information here. So for example, this is a case of branch retinal vein occlusion. So you could see that there's a hemorrhage over here, and the fluorescence was broke in this area, okay? And the left eye was normal. And finally, we would cover the ERG, VEP, CT, and MRI. So sometimes you cannot see where is any abnormality of the patient. You want to check whether the whole visual pathway was normal. Then you could use either ERG or VEP. The ERG, electroretinogram, was used to measure the retina function. So use electro, it's like a EKG. You use the machine to test the health of the of the heart, but you use an electroretinogram to test the health of your retina. So you get the responses of the signal from the retina. And the VP, with VP, we test whole visual pathway. So this is different. ERG, we just recall the response from the retina. So you get the information from the retina only. But the VP, we try to test the whole visual pathway from the optic, the eye, optic, horizon, the optic tract, the visual cortex. So if any one of these area have abnormality, you would get a normal VEP. Okay. So if any lesion was present in this visual field, in the visual tract, you will see different abnormal responses, the waveform from this test. Then finally, I would like to cover the CT and the MRI, the more advanced instrument used for the certain cases. For example, in this figure, you could see there is a this is an orbit, and there's a inferior orbital wall fracture, and there's might be some blood going to the sinus here. So you have, if a patient have a trauma and cause orbital wall fracture, you might need to do a surgical intervention for the patient later. And for this patient, you can see there's a foreign body in the left eye here because of the trauma history. You need to verify whether there's a retained foreign body in the eye. So this is an MRI. You could also provide detailed information. For example, you could see that at the base of the optic nerve, there's an information of the optic nerve head. So you could get the information outside your eyeball. Okay, so probably I have covered all the major eye examination for you today with my lecture. And at the end of my presentation, I would like to give you additional information how to protect our vision. There are a couple of tips useful for maintaining good vision. I think the vegetable dye is very good for your eye. And also, when you go outside, you need to put on sunglasses, and frequent exercise and adequate amount of sleep is essential for maintaining good vision. So don't use too much computer. Need to take a break. And finally, I have a couple of questions for the student to add more score. So the first question is, which of the following can measure the patient's visual field? Chung Yi Shun, do you know which one?
Is it automated perimetry?
Yes, automatic perimetry. This is a instrument we could use to test the patient's visual field defect. Correct. So what's your number?
Sorry, doctor, I'm not sure about the number. Yeah.
Oh, you don't know your number. Okay, okay. The next question, which of the following can measure the retina vasculature in detail? Let me ask one question. Zinc. Muhammad, Azin,
Yes, doctor.
which
The answer would be B, OCT angiography.
oh, very good. Correct. Good. And for the next question, which of the following examination is not related to strabismus? Ankindun, Ankindun, Ankindun. Or Chen Yu Moon, Chen Yu Moon. Chong Vivian. Is Chong Vivian here? I cannot hear you. You might need to unmute yourself. Okay. The correct answer is ultrasound. Ultrasound was used to examine the posterior pole of the eye, mainly the vitreous and the retina. And which of the following is the most useful for a patient with suspect orbital wall fracture? Zhongji Hui. Zhongji Hui. Or Chong Shu Chi. Okay, I did not hear you. So the correct answer is a CT, because if there's a foreign body, we don't want it to be moving inside the eye while we do the examination, because if you use the MRI, because of the magnetic field, the foreign body could move in the eye. That would cause further damage to the eye. So we don't want to use MRI. We prefer to use CT scan for the patient under such scenario. And I think this is the last question. What can occur when there is a tumor compression? The optic chiasm. This is this has been mentioned several times. Or Tim Fan.
D, bitemporal hemianopsia.
Yes. Yeah, I think you have paid attention to the class. Very good. So I hope all of you have learned the basic knowledge about the eye anatomy and the basic examination, numerous basic examination for the eye. And I do hope that we can work together in the future if you have a chance to visit our hospital. And hope all of you have a great day. Thank you.
Thank you.
Thank you.
Thank you.
Bye-bye.
Thank you, doctor.
Bye-bye.
Thank you,
Bye.
doctor.
Thank you, doctor.
Thank you, doctor.
Bye-bye.
Thank you, doctor.
You're welcome.
Thank you.
You're welcome.